Hello, it's Rockson Liu again from Emeryville, California, dedicated hernia surgeon. Today I'm going to switch topics and talk about ventral incisional hernias. Now, this is a really big topic and I don't even know where to begin. But let's talk about the basic hernia that a lot of patients have, which is the umbilical hernia or something called an epigastric hernia, which is a hernia in the upper belly above the belly button in the middle, right? Most of the time it's a little piece of fat that's in there. Maybe you have a bigger one that has a little bit of your intestines in there. The hole, which is in the fascia, is usually small, 1 to 2 centimeters, and it can be symptomatic or not symptomatic. A lot of people are born with outies, and outies are hernias. So if you've had an outie all your life and it's the same, don't let anybody operate on you, because if you've had it all your life, it's not a problem. We find these on CT scans. A doctor sometimes will point it out. That doesn't mean you need surgery. The ones in the above the midline, above the belly button in the midline, those are a lot of times those look like little fatty lumps, and they don't go back in because the hole is so small. If they're not bothering you, you really don't need to have them fixed. The small ones, it would be hard for your intestines to get in there. But have a surgeon check it out. If you're not sure, because some are big enough. If you're really thin, there's very little fat. Sometimes your intestines can get in there and it can strangulate. But for these small ones, the chance of strangulation is pretty small. And I really only offer surgery to patients who have symptoms, right? So if you're having pain, if whenever you press against it, it's hurting, then I would say you probably should have a fix, because we have very simple surgeries for it. Now, I'm a robotic hernia surgeon, and I can do some pretty amazing things with a robot. But for these small hernias, I actually just offer open surgery in general. If you're thin, if you're not overweight, you don't have a lot of complicating factors like smoking or poorly controlled diabetes, then an open surgery is very good. It can usually be done with just sedation, with what we call a MAC, monitored anesthesia care. The anesthesiologist will give you propofol. You'll be asleep during the surgery, but no breathing tube. And these surgeries can be done in the surgery center, usually in and out surgery. Probably take me 15 minutes to do the surgery, a little incision right over the lump, remove the fat so you lose a little bit of weight. Okay, everybody likes that. And then there's going to be a little tiny hole in the fascia, and usually it's just a stitch or two. If it's big enough to tuck a piece of mesh in, frequently I'll tuck a piece of mesh in, and that defect would have to be about a centimeter or centimeter and a half. Because studies show that if it's less than a centimeter, adding mesh really doesn't improve the outcomes, right? And I like to put mesh in where the pressure is coming from, so I like it under the fascia. And if it's a small hole and I have to make the hole bigger just to tuck the mesh in, it makes no sense to me. Defects between 1 and 2 centimeters, studies have shown that the recurrence rate's a little higher if you don't use mesh. And I would say, if you're young, healthy with robust fascia tissue, maybe just sutures is fine. But between that 1 and 2 centimeter defect size, I put mesh in if there's any weakness, or I feel like the tissue would just need support with the mesh. And the mesh I would use is, again, a permanent mesh, but there are resorbable options like Phasix available for those repairs. And then above 2 centimeters, I definitely recommend some kind of mesh reinforcement. Okay, so those are kind of the smaller hernias. Now, there are small hernias that I would do robotically. Okay, and what are those hernias? Mainly, it's patient factors. Number one is if you are really overweight, if your BMI is over probably 32, 33, you have a big beer belly, or you have something called diastasis recti, where the rectus muscle, which are two muscles, paralleling muscles, are separated. So down the middle, there's no hole, but you have just fascia. And that is a weak tissue that if I put stitches in, will probably rip through. So overweight patients with diastasis, even if they have a small 1 to 2 centimeter hernia, I recommend robotic surgery, because I can get a nice big piece of mesh and I can sandwich it between layers, and I can not I can avoid fixation to the diastasis. Now that's a very important technical nuance or distinction between what I do, which is a TAP, transabdominal preperitoneal repair with preperitoneal mesh, compared to something called IPOM, intraperitoneal onlay mesh, where a surgeon takes that coated mesh and just tacks it up to the ceiling. And I had mentioned this earlier, but with these IPOM meshes, number one, the mesh is touching the bowel, which I don't like. Number two is what's more relevant in this discussion is that it requires circumferential fixation, meaning that mesh doesn't just stick up there, right? It's not sandwiched between layers, so it needs to be fixated. And usually we suture all the way around robotically or laparoscopically, use these transfascial sutures that go through the abdominal wall and we tie it down, or we use tacks all the way around. And in the middle, where there's diastasis, that tissue is it's strong in the sense that by coughing and sneezing, you're not going to put a hole through it, right? But as soon as I injure it with a needle, with a suture, with a tack, that becomes a weak area. And when you cough and sneeze, the suture or the tack can rip through very easily. And so a lot of recurrences happen at the epigastric 12 o'clock position with these IPOM meshes. So if you're overweight or you have diastasis, the last thing you want is an operation that will injure the diastasis. And the open repair, the laparoscopic repair, and the robotic IPOM repair all injure the diastasis and the recurrence rate's higher. So that's why I do the robotic repair. I peel the peritoneum down. I place a big piece of mesh with good overlap so that even if you cough and sneeze, or if you're really overweight and generate a lot of intra-abdominal force trying to push that mesh through, because it's sandwiched between layers with a lot of friction across the entire surface area, that mesh is not going anywhere. And because there's no fixation to diastasis, to the weak tissue in the middle, there's no weakness to this repair. So in the literature, with the traditional methods, the open laparoscopic methods, the recurrence rate in somebody with diastasis is about 20%. For us, without diastasis, is about 2%. With the TAP repair, I've not seen a recurrence yet in overweight patients, and I operate on some very overweight patients. You may have a surgeon that tells you, hey, you're too overweight, you got to lose weight, you got to bring your BMI down to 40 to 35, whatever the cutoff is. With this TAP repair, we don't have to worry about it. Okay. Now, back to the surgeon's skill and abilities. Again, a lot of surgeons will say, oh yeah, I'll do the TAP repair. Maybe you watch this video, you go to your surgeon and say, hey, Dr. Liu says do a robotic TAP repair because I'm overweight and I have a diastasis. They're gonna be like, great, okay, that's what I'm gonna do. Well, what is their success rate? What is their conversion rate? I can tell you a TAP is, even though this is a small hernia, it's technically one of the hardest operations to do because the peritoneum is so thin. I need to have a lot of finesse. I have to be very gentle. I have to be able to coordinate my two hands to bring that very thin peritoneum down. And even for me, I'm probably successful only 90% of the time, not 100% successful. But it's very hard to reach 90%. And I can tell you a lot of surgeons would end up converting to an IPOM operation because they can't get that peritoneum to come down. And then now you're getting an inferior operation with a 20% recurrence rate. So you got to be careful picking your surgeons if you have a small umbilical hernia and you need a robotic operation because of these factors that increase the recurrence rates. Okay, I think I've spent enough time talking. This topic, again, is extremely vast, and I'm going to spend lots of time on and talking about ventral and incisional hernias because I have so much to say. So stay tuned, all right?